everyone for coming. My name is Keely, if you haven't met me before, Keely Behning. I'm a physical therapist. I work inside of the club here. And I have Dr. Sarah Jonjak here today as well. She's a pharmacist and functional medicine practitioner. So I'm going to start off the talk, give you a little bit of background. She's going to come in with all the good stuff, and then I'm going to wrap it up with
They were really already excited about the jumping. So.
Oh, yes. Yes, we will jump today. Test. Some people will jump. Some people will think about jumping. We'll do our pelvic floor class after this. So, okay, so this is the perimenopause, menopause talk about inside-out wellness strategy. So this workshop is perfect for you if you've ever done that. I did that last weekend. So if you want to know a little bit more about perimenopause and menopause, learn about what the most common symptoms and kind of challenges are with this phase or whatever transition, and you want some guidance about what you can do about those symptoms and challenges. And the things that we're going to talk about today is lifestyle, exercise, nutrition, supplements, prescriptions, hormone, that kind of thing. So today you're going to learn those common issues, be able to apply them to your life, and then understand options for individualized programs. So if you're already dealing with symptoms, realize that today this is neither physical therapy nor medical advice. This is just general advice. I think it's applicable, and I think it's very helpful, but it's not customized to any of you. So if you have some more significant issues or health concerns or whatnot, just realize that would require you doing individualized care with a healthcare practitioner. Okay, so my background, why am I talking here? My undergrad is in exercise physiology. I went on to become a certified athletic trainer. I went to physical therapy school, became a physical therapist, and then I went on and did a residency in sports medicine, studied that for a couple years, and now I am board certified as a sports clinical specialist. So, and later on, you'll find out my age and why this topic is very relevant to me. So a little housekeeping. We ask that you don't mention your personal health information here today for HIPAA reasons, and also because I am recording this and it will be online. So, but if you did have questions that were specific to you, we can answer those privately after. I'll turn the microphone off. And also make sure that we can answer those also if you want to email or text or call or set up an appointment. So just confirming that this is on. Yes, okay. And our contact info is here, but I also will have it at the end. And if you kind of flip over the backs of those sheets, that's how you can schedule with each of us. But the contact information will be at the end as well. So first I'm going to go over the objectives. So we're going to describe the hormonal and physiological changes that happen during perimenopause and menopause, identify those common symptoms and challenges, talked about some of the concerns are the symptoms, weight gain, osteoporosis, hormone replacement, overall health, and those things can be addressed through those different methods we talked about. And then I'm also going to summarize some research on how exercise will impact bone density, weight gain, mood, sleep, cognition, and discuss some evidence-based exercises specifically for this transition period, they're calling it. Okay, so just a little definition. So premenopause is the start of menstruation until you're in perimenopause. So, and then I'm not going to talk about that phase. I'm going to talk about the other phases here. So perimenopause, the actual definition means around menopause, and it's referring to the years leading up to menopause. So during that time period, your ovaries are producing a little bit less estrogen, typically begins in your 40s, can be a little earlier, can be a little later, and can last months to years, but the average time length is about 4 years. So common symptoms during that time period, irregular periods, they can be shorter, they can be longer, they can be heavier, they can be skipped. The dreaded hot flashes and night sweats, mood swings, irritability, anxiety, sleep disturbances, whether they're from the hot flashes or not, vaginal dryness and discomfort during sex, decreased libido, brain fog, difficulty concentrating, increased urinary urgency. All of this sounds really great. And then, so menopause is actually officially diagnosed, I don't know if that's really the right word, but maybe, is 12 consecutive months without a menstrual period. So technically menopause is a period of time. And as soon as you hit menopause, you're now in postmenopause, if that makes sense. So the end of the reproductive years, around the age of 52, and that's when your ovaries have stopped releasing eggs, your estrogen production will drop significantly, and you get those hormonal shifts that lead to a variety of symptoms. So again, postmenopause is the stage immediately after menopause, and it lasts for the rest of your life. Some symptoms can persist, and then we also get some health risks like osteoporosis and heart disease due to the lower estrogen levels. Okay, so we're going to talk about why this all happens, and the main reason is some shifts in our hormones. So there's a decline and a fluctuation in estrogen and progesterone. Those are the female sex hormones made by the ovaries. And so, the irregular ovulation basically causes skipped ovulation altogether will cause a reduction in your progesterone. And then the estrogen levels are going to fluctuate unpredictably. And so sometimes spiking, sometimes plummeting. So then we have kind of early hormonal changes when you're 35 to 40. So you're still ovulating regularly, menstruating regularly, and you're still getting that predictable rise and fall of the estrogen and progesterone, but your fertility would start to decline some. And then when you're 40 to 47, we're calling this kind of early perimenopause, where your ovulation becomes more irregular. And then the progesterone would decrease because it's only made after the ovulation. And your estrogen, like I said, fluctuates. It can surge and drop. So you're getting those heavier periods, skip cycles, mood swings, breast tenderness. Late menopause, they're calling 47 to 52. So the ovarian function declines significantly. The estrogen starting to swing wildly. And we have those changes in the cycle because of that. And your symptoms will intensify. So hot flashes, insomnia, irritability, brain fog, joint pain. And then menopause, 51, 52, no period for 12 consecutive months, but your estrogen and progesterone are going to remain low now and more steady. And then symptoms persist, but often will stabilize. And then the postmenopause, we have permanent low estrogen. And so that's why we have that risk for osteoporosis, heart disease, the vaginal dryness. And then some women will continue to experience the hot flashes or other symptoms for many years. Okay, so now we'll pause here. So now we're just going to go over all the good stuff that estrogen does and all the good stuff that progesterone does. So you kind of understand, if we have less of those things, how it can impact so many different areas. So estrogen supports our neurotransmitters. If you've ever heard of serotonin or dopamine, those things help regulate our mood and our emotional resilience. Also, estrogen helps with our cognitive function and our ability to regulate our temperature, which is why the hot flashes and night sweats occur. But estrogen also helps our cardiovascular system. It makes our blood vessels kind of flexible. It keeps our cholesterol regulated, and it helps protect us against plaque buildup. So you're at a reduced risk in general for heart disease before menopause, and then it goes up. Estrogen helps our bones by inhibiting bone breakdown. It promotes calcium absorption to maintain your bone density, and that's the major reason why you're at risk for osteoporosis post-menopause. Estrogen also helps our muscles and our connective tissue by supporting your muscle mass and strength. It influences your collagen production, so it keeps our skin elastic, which is important for skin elasticity, so don't get so wrinkled, but our joint health and even the pelvic floor integrity, which we just talked about. Skin and hair with collagen that affects the skin and hair as well, and also hair growth and thickness. We can get thinner hair as estrogen drops as well. Also helps with metabolism, fat distribution, so it affects our insulin sensitivity and fat storage. So after menopause, the fat tends to shift more from the hips and thighs, more to the abdomen, which we know puts people at risk for metabolic disease. And it also helps support urinary and vaginal health with that tissue elasticity, lubrication, and it supports urethral and bladder health, so reduces urgency and infections. So estrogen does a lot of things that we don't think about, and progesterone has a lot of other things it does besides what we know it does is regulates your menstrual cycle. It prepares your uterine lining for implantation. If you don't get pregnant, the progesterone drops and that triggers your menstruation. So if you have low levels, you'll have irregular or heavy periods, which is what we start noticing perimenopause because your ovulation has become a little more erratic. So progesterone also helps brain and mood. It's kind of a natural chill pill. It has a calming anti-anxiety effect. It helps sleep quality. And there's also some study for its role in mood regulation and postpartum depression. So it works along with estrogen to maintain our bone density. It regulates bone turnover, so it can reduce the risk of osteoporosis if it's balanced. The cardiovascular system, it helps support that vascular tone. Endothelial is like the inside lining. So it contributes to your heart health, can help regulate blood pressure and reduce inflammation in the blood vessels. And progesterone also helps with our immune system. So one of the things it's doing is to try to prevent your body from rejecting the embryo, but it also helps maintain that throughout the body. So if you have less progesterone, you can have an increase in autoimmune flare-ups. It also helps with lactation, so prepares your breast tissue for milk production. So it reduces tenderness that we get from estrogen. Okay, now hot flashes. So I wanted to talk to you a little bit about hot flashes. I learned a little bit more about this, which is interesting to me. So when the estrogen levels drop, that affects those neurotransmitters we talked about. And that those changes make the hypothalamus hypersensitive to small temperature changes. So think about, in your younger years, if your temperature 98.6 or whatever it is, you have a certain amount of fluctuation, a little bit above or a little bit below that, where you won't notice a change in your temperature. You're not going to start sweating. You're not going to start shivering. You have a certain range. And what happens in perimenopause, menopause is that starts to shrink. So now I can have just a small increase in my temperature, and my body kind of misreads it as me being very high temperature. So it's going to flush me, right? And make me sweat, trying to cool me off. And then that's going to make me drop my temperature too low. And again, my range, it doesn't tolerate much above or much below. So now I'm too far below. So now it's going to try to heat me up. And so you kind of go through this little vicious cycle where it's kind of overcorrecting itself. And so it's a little misinterpretation and overreaction that happens that makes it a little bit of a feedback loop that keeps that cycle going. So that is my background. And now Sarah's going to come up and talk about her talk, which is nutrition, supplements, hormones, medications, that kind of thing. And then I'm going to hop back in on the exercise portion.
We have to change the input, right?
Yeah. Yes. Did you turn that microphone on?
Yeah, I had it on the whole time. So
Okay.
You probably heard me breathing through your...
Do I have to unplug this?
No, I think you just got to move it back. Oh, maybe not.
There we go.
All right. Well. This is my visual of menopause. Kind of everywhere. So my name's Sarah. I am a pharmacist. I know Keely from, I would say softball would be the connection, mutual friends. But I did nuclear medicine for a long time. I worked at North Memorial Hospital for about 20 years, and I got laid off for workforce reductions, and then I had to do something else. So I went in back to school to get my doctorate in pharmacy. I'm licensed in Minnesota and Wisconsin. I, at the same time, said I'm never going back to school again. So I also got my master's in public health. And I'm a certified functional medicine practitioner and a CrossFit level 2 trainer. If you've never done CrossFit, you should, because it's great. And I do coach it. So I would say the biggest thing I hear at pharmacies are, am I going to gain weight? What's wrong with me? What's going on? What happened? I woke up and all of a sudden I'm sweating. I don't know what's going on. Who am I? Why am I angry? I hate everybody I know. And you're kind of like, yeah, it sounds kind of like menopause, perimenopause phase. So overall health, I'm just going to give you the baseline I would give any woman for like nutrition that I think everybody should be doing. But there are some things that we can do plus or minus depending on where we are and our goals. So Keely mentioned hot flashes, night sweats, vaginal dryness, painful sex, irregular periods, and mood swings. I would say those are the top. There are, bladder problems, but that could be not just because you're in menopause. It could be things other than that. And you can deep dive and go down a rabbit hole for a lot of things that could be triggered because menopause started. Like some people might be migraines, some people it could be a lot of things because your hormones kind of rule the world. And then when you get one less, then the world's kind of shifted. So we'll go over the big ones. But this is my general nutrition plan for any female if they were to come see me. I recommend 120 grams of protein daily. The only reason it would be lower than this if you were a very small female, maybe 4 feet tall and 100 pounds, you might not need a whole 120 grams. But things Keely's going to talk about, we want to keep our muscle and our bones, and we need protein to do that. We just can't create something from nothing. We also aren't going to gain muscle if we just eat a bunch of protein and sit on the couch all day and watch Netflix because we're crying because we're so upset that we're in menopause. So it's like a give take. Like you can eat too much protein and that can be bad for you. You can eat not enough protein and that can also be bad for you. I tell people they should just align their plate. I don't care what you do beyond this, but if at every meal you think I want to have a protein, a plant, and then you decide to throw a pizza on top of it, great. At least we've hit protein, plant, and we've gotten micronutrients and our macronutrients balanced so we can say, okay, I can feel better about the pizza. Maybe it's not a whole pizza because you do get cravings in menopause. The things you feel in menopause kind of feel like PMS. Like when you're PMSing before you get your period, it's kind of like the reverse of that. Like, why am I starving? Why am I angry? That kind of thing happens. So weight gain is a side effect of menopause, but the rules for weight gain are the same. If you eat more than you burn, you're going to gain weight. So what happens a lot of times in menopause, people slow down, they stop their movements, they stop these things. So keeping your macros balanced with that protein plant will really help you be successful in not overeating. And if you do overeat, it won't be as bad. I say 48 ounces of plain water. If you love green tea, great. I like green tea, but not my favorite thing. But plain water, just because there's so much junk you can put in there that can just go against your goals. Being hydrated is big. As we age, elderly people are not hydrated at all. You want to keep your joints, you want to keep your muscle, you want to keep your iPad going. But mainly, hydration is key. And as we get older, it's harder for us to think about drinking water. We lose our schedule. We don't think of those things. And then 1,200 milligrams of calcium daily. So you can eat that. I prefer people get their calcium from foods. Some people do find in menopause that dairy becomes a problem and it triggers symptoms. So there's other ways to get calcium, like your green vegetables, the dark green leafy greens. That's a great way, like sesame seeds. If you are like a tofu person, they make tofu that's made with calcium actually, so you can get it that way. If you don't love dairy, and if dairy causes your symptoms, because some dairy can. There are some specific foods that are beneficial. Edamame or soybeans, a half a cup contains this thing called isoflavones, which acts like a phytoestrogen. So it binds to those receptors that Keely was talking about that is looking for estrogen. And when you don't have it, the phytoestrogen binds and it kind of like brings that thermoregulation back to normal. So your body's not like, oh, we're at empty. Now we have a little bit more. So a half a cup provides 150 milligrams. I don't know if you've ever gone and had sushi. A half a cup is probably 4 times what they serve you, so you get like a lot depending on how many of those little things you eat. But you can get it where it's not in the shell, and half cup is a lot of those little beans in there. So I think it's an easy way. It's easy food. Again, your body knows what to do with food. Sometimes it doesn't always know what to do with supplements. So the more natural, I think, the better. But it's up to you. I don't know if you guys are familiar with royal jelly. It's kind of like the honey of all honeys that the queen bee has blessed herself with everything. Some people take it when they're having like fertility issues. It does contain this 10-HDA, which is a very long chemical name, that has estrogenic properties. So it can help balance out estrogen for people with high and low. So that's why they recommend it in fertility. And it also can be recommended during menopause to help with the vasomotor symptoms. So you don't want to go.
And vasomotor, you mean?
Oh, sorry. Yeah. Vasomotor are the ones where you're like sweating and crying and the night sweats and the big changes from like sweating to chills, waking up. A lot of times people wake up and they don't know if they had a night sweat, or it could you had a night sweat and that woke you up. So that can really help with that as well. So supplements, again, this is my baseline for everybody. 3 to 5 grams of creatine monohydrate daily. Some of you are pickleballers, it sounds like. If you're active, this is really good for muscles, but they also have found this helps with memory and dementia prevention. So all women, if they're very active, that 5 grams is fine. As Keely has learned, you want to still be hydrated when you take that. It does take muscle. It can take water from your muscles and give you some cramping if you aren't hydrated enough. So being hydrated is good. If you're not as active as you think, like athletically, 3 grams is fine, but they have found that it does help with maintaining muscle and memory. Vitamin D, I think the best way to get it is to go outside. We all live in Minnesota. January, maybe people don't like to do that. So you can still get vitamin D in January. You just got to be outside for maybe 30 minutes. In the summer, 10 to 15 minutes is totally fine. That's all that you need for your vitamin D outside daily. You can take it if you are like, absolutely not, I should have moved to Florida this summer or this winter. I'm never going outside again. Then you would do the supplement, but I think most of us can tolerate a 10 minutes outside at least to get our vitamin D. It's hard to overdo vitamin D, but again, you don't need to do the 10,000s or the 100,000s that I've seen people do over the counter just because more is better. But in this case, more is just more. So as long as you're getting like about 2,000 a day, if you're unable to go outside, then that is fine. Calcium from foods. Again, think of your yogurts, think of your milks, think of your cheeses are the big ones because I'm from Wisconsin, so who doesn't have cheese at every meal? But if it does give you intolerance, you can look at say, okay, I had 2 glasses of milk, so I'm probably at like 600, then I just need like 600 milligrams supplement if you don't get it from any other foods. So 1,200 is the total between supplements and food. You don't want to just take 1,200 blindly and eat a lot of dairy. There's no need for that. But if you're unable to eat it, especially as you get older, sometimes hard foods get harder to eat. The supplements can help. But milk is always an option. And if it needs to be chocolate, let it be chocolate. So this is specifically for vasomotor symptoms. So vitamin E is an antioxidant. I put it in the 8,000 IU. If it's milligrams, it would be about 500 milligrams for the 800 and 250 milligrams for the 400 IU. They like convert them now. So I don't know what it would be on the shelf for you because I've seen it both. But vitamin E, so they did this Women's Health Initiative, which I don't know if you guys are aware of, was this big study where they looked at 160,000 women. They actually stopped it early because of things that they found. So one of the things they found is that we don't want to get more than 1,000 milligrams of vitamin E a day. So that's why we keep it down to that 500 level. But it does help with the hot flashes and the night sweats and the sweating. And they think it's the antioxidants, but they don't know for sure. They haven't really pinned the one thing that makes it great for us. But that's something that you can get at any store. You could buy it tomorrow. It might be in your multivitamin, if you guys are on a multivitamin. Just make sure you're getting enough because sometimes you're not getting enough. So then can
you explain again for some of us. So IU.
Yep, it's an
versus-
international unit. So like
Yeah.
vitamin D used to be in international units, and now the FDA says that everything has to be in milligrams, but the labeling hasn't changed. So 800 IU for vitamin E is about 500 milligrams. So it'd be 500 milligrams, and then 400 would be about 250 milligrams. It's just how they label it. They're supposed to have both on there, but a lot of them drag their feet. So it's just another way of dosing nomenclature, how they say it. So yes, thank you for pointing that out. So I say plus or minus one below. Siberian rhubarb, what that does is it binds to beta estrogen receptors in your body. So again, when your body's like, my estrogen's low, I have all these receptors, they're not doing anything, I'm freaking out. The rhubarb can bind to some of those and calm your body down and think, oh, the estrogen's back. And then like Keely was saying, your little range of hot flashes goes from here to here because it thinks you have more estrogen and it's not like in panic mode. So that's what the rhubarb does. The black cohosh works on serotonin in your body. I will say black cohosh does interact with a lot of prescription medications. So if you're currently already on like antidepressant or that type of a thing, you will want to check with a pharmacist or your doctor before you start a black cohosh, because that can change your mood a lot more if you're on something that already affects your mood, like a Prozac or a sertraline type of a thing. So black cohosh works with increasing serotonin levels in the body, and that can help your hypothalamus say, you know what, we're not as scared as we were. You're not tipping over the edge. So
Where does one get the rhubarb?
I have a supplement you can get, but I believe most Whole Foods would have it. It just comes up as just a rhubarb. Sometimes it's called like Estrovera. So if you've seen like Estrovera, it's usually the rhubarb, which I believe all like Walmarts and Walgreens and CVS's all have Estrovera on their shelf. So this is mainly for just vaginal symptoms. The vitamin E comes in creams or ointments, and you can use that for dryness, losing estrogen in our body. They call it vaginal atrophy, so it can shrink because it loses its plushness. The vitamin E cream helps keep that. So OTC is over the counter, something you can buy at the store. Replens is just a moisturizer that's a long acting, so you do it like once every 5 days. Luvina I haven't seen as much, but it is something that's out there that also moisturizes, and I think that's like one every 3 days you would use vaginally. Astroglide is specifically recommended for painful sex because it's like a water-based lubricant, and it doesn't have any of the parabens in it, so people prefer that, so they're not absorbing vaginally any of the like preservatives in there. It's just more water-based. So if painful sex and vaginal symptoms are very severe and you're still having issues after using like a vitamin E cream or some of these supplements, at 2 months you can add something called kudzu. You would probably have to order that from like a specific Whole Foods or supplement store. I don't see it like just out on the shelves. Online you can get it, and that can really help with more vaginal symptoms if trying the other things didn't work. So I haven't seen it. I don't know if it's really expensive. It could be. I have no idea. I haven't price checked it, but I don't really know much people that need it beyond using the ointments already, that those already help them. So if anxiety and depression is a concern, kava extract and hops extract help with specifically anxiety and depression. Sometimes we get more anxious as we age naturally. It's not always connected to estrogen. It's just something that happens because some people, fear of death, fear of losing their, they're retiring and they're losing their social circle. They're doing other things that they've never done before. They don't have a schedule. So the hops extract and the kava extract have been shown to specifically help with anxiety and depression. Again, if you're already on an anxiety or depression med, you'd want to check with somebody because you don't want to double up on those things because your mood could go real bad or real crazy. You could be manic or something like that. We don't want that either. So hormone replacement, there is definitely a specific time frame when you want to do hormone replacement, and it's for specific people. So what they found in that Women's Health Initiative study that they ended up ending early was that if you're 60 and under, within 10 years of menopause, then hormone replacement therapy is great for you. You lose the risks of what they saw in that study. If you start hormone replacement therapy after 60, you have a higher risk of stroke, you have a higher risk of breast cancer, and you have a higher risk of like heart events because of blood clots. So that's why they put that limit on 60. If you take estrogen therapy at like 59 and then you turn 60, it's not that they automatically stop it. They just say, you know, just be aware the risk to benefit might have changed for you now. You might not want to keep doing it. See where you're at. You might phase off of it and see if your symptoms are still bad. And then you might go back onto it if the symptoms are so terrible that you can't, you know, get through days without it. But estrogen is used for women who've had a hysterectomy, and then estrogen and progesterone are used in combination, and that decreases the risk of cervical cancer because what they found with the progesterone, it helps shed that lining that gets created in the uterus. So it brings that risk down so you don't have what they call hyperplasia or over cell growth in the uterine lining. So that's why they do the estrogen and progesterone to help shed that layer so you lower your risk for the cervical and uterine cancers. So if you are healthy and you're within 10 years of menopause, estrogen or estrogen plus progesterone may be a great thing for you if your symptoms are interacting with your daily life. You know, you can get a patch, you can get creams. So there is vaginal creams that people use. There's patches that go on. It's an oral tablet as well. There's many ways of doing it that people find are, you know, it's kind of like it's nice to have choices because if one doesn't work, then you can try another one. And you can start just locally. You could just do the vaginal. And if that helps, then you don't have to get it through your whole system like a tablet would do. So the benefits of these, as Keely said, when you're under 60, that's where they see it can lower colon cancer, it can protect the heart, it's good for the blood vessels, the bone density is higher, and it controls definitely the hot flashes symptoms. It's that 60 to 65 and older is when it becomes more of a risk than a benefit. Again, the endometrial cancer, but the progesterone can reduce that. So VTE is a blood clot. And using the patch over the oral tablets actually can reduce the risk of blood clot, but there still is a higher risk of blood clot with the patch than not taking the estrogen at all. If you're over 60, coronary heart disease is a concern. It can also lead to stroke and gallstones. So again, it's a risk-reward thing, but some people have such bad menopausal symptoms that they can't get through their day without hormone replacement. But the goal isn't to be on forever. You know, it's to get you through the part of actual menopause, that perimenopause phase, and then hopefully postmenopause, some of these symptoms go away. And then, like I mentioned earlier, the progesterone sheds the uterine lining, which helps decrease that cancer risk. And there are some side effects that people don't really love. You get spotting of blood, mood disturbances, breast tenderness, and headache from the progesterone. And you can also have that without the progesterone. So it's sometimes what's the pill and what's the body. It's hard. With the hormones, it's hard. There are non-hormones. I put them on the sheet that I gave to you guys. So paroxetine is a serotonin uptake inhibitor. So it increases serotonin in the body. So that really helps with the vasomotor, the sweating and the hot flashes. Venlafaxine works on serotonin and norepinephrine. That also helps with those symptoms. Clonidine increases those serotonin levels, and gabapentin doesn't work exactly on serotonin, but the nice thing about gabapentin, I don't know if any of you are people that are in pain, gabapentin can help with nerve pain and help with the hot flashes as well. So if you currently take gabapentin because you experience like an injury or you have chronic nerve pain, some people use it for things like fibromyalgia. It might already be helping you with hot flashes and you didn't know it, but people can kind of get a 2-for-1 out of that if there's chronic pain and they need a pain med. Again, these are all prescriptions. This would be something you'd see a physician about. Pharmacists can't prescribe, unfortunately, but it would be low dose paroxetine and low dose because you don't need a high dose to help with the symptoms. like you would if you were treating like depression or major depressive disorder. So it's actually a very low dose of the venlafaxine and the paroxetine compared to when you take it for actual mood disorders. And then lifestyles, Keely.
Okay. So these are some common physical therapy complaints we see with menopause. Obviously, not all joint pain comes from menopause, not all frozen shoulder, but we see an increase in some of these during this time period. So we'll go over some of the kind of briefly why those things happen. So for joint pain, that low estrogen level leads to that increase in the inflammatory protein. So inflammation kind of goes hand in hand with joint pain. So we can see an increase in that. Frozen shoulder, there was actually a study that looked at women who took hormone replacement therapy, and those women had lower percentages of frozen shoulder than the general public that was not on hormone replacement therapy. And that's kind of the peak ages for frozen shoulder anyways, kind of 40 to 60 years old. Headaches, just because headaches can be associated with those hormonal changes, if you're having hormonal changes during this period, that can also trigger headaches. Vertigo, this one was actually new. I didn't realize that there was any relation to hormones, so this was good for me to know because I treat vertigo. So the way that it affects your inner ear is, so for a very brief explanation of vertigo, is you have crystals in your inner ear, they become dislodged, and then they get stuck in the wrong part of the inner ear. And so those hormonal fluctuations can lead to dislodging of the crystals, and it also alters the viscosity or the volume of the fluid that in the inner ear where the crystals are. So vitamin D, which I did know of, decreases your recurrence rate of vertigo. And what I didn't know was also hormone replacement therapy also shows a reduction in recurrence of vertigo, and combining them was even more effective. And I'm not sure that they're prescribing this specifically for that or not, but kind of good to know. Because a lot of people, once you've had vertigo, they ask me, how do I never have this again? I got vertigo a year ago, very young. And so I'm making a mental note of this one for myself. So exercise is kind of what I'm going to talk about today. So what is it good for? Everything, right? So if someone said, I want a magic pill that does everything, exercise is it. So important. So maintaining your bone density, muscle mass, obviously cardiovascular health, helps you sleep better, improves your mood, mental health. Those vasomotor symptoms are the hot flashes, night sweats, supports your weight management, makes you more flexible, improves your balance, protects your cognitive function, regulates your blood sugar and insulin. Now, I looked at specifically research on exercise in this kind of age group, or this group of women with menopause. And so this is basically a systematic review of other systematic reviews. So this is looking at lots of big studies. And they found that yoga was very helpful for helping with physical complaints, urogenital. So I think, I don't remember if it was exactly what part of urogenital, if it was symptoms of the dryness or stuff, or if it was like loss of control of bladder. I don't remember what that part was, but urogenital and overall menopausal symptoms. And then aerobic exercise, they had some mixed results, but very promising for those vasomotor symptoms like the hot flashes and overall well-being. Another one was looking specifically at strength training and that's effect on your symptoms. And they found that strength training improved your pelvic floor and leg strength. your bone density, those hormonal and metabolic markers, and then hot flash frequency and intensity. So most people have done some type of strengthening in their lifetime, but I wanted to mention that strength training can involve anything from body weight, free weight where we have like little dumbbells in our hand, resistance bands, it can be machines, or if you look at the end, really heavy stuff, kind of Sarah does with the CrossFit is a heavier type of lifting, which back when I first, honestly, as a physical therapist, I hear about CrossFit and it makes me like, oh, the rotator cuffs. But there's more and more research that heavier lifting, if done right, there's some modifications we have to do for certain injuries and such, is really helpful. So how does it help with bone health specifically? So there's something called Wolff's Law. And all this means is that if you put force on a bone, a mechanical stress, it'll respond to it by putting down more bone. So if you think about astronauts, one of the things they're really worried about is they don't put any weight on their bones when they're in space. And so they look for whether they have osteoporosis and whatnot. So while we're weight bearing on our bones and walking around, we are building up bone mass. But strength training, when I take a heavy weight, my muscles connect to the bones. That's how we move. So it pulls on the bone. It'll make the bone stronger. It also helps with your bone mineral density, which is really important in your spine, your hips, your wrists, which are vulnerable to osteoporotic fractures. And it also reduces your fracture risk by giving you more muscle strength to help cushion the impact and the forces. And strengthening helps you with your balance and ability to kind of control your body in space, which is also important for preventing falls. So how much and how often? So we're aiming for 60 to 90% of a 1 rep max. So 1 rep max means I can literally only lift that thing one time. It's a huge struggle and I'm not gonna make a second rep. So that's your 1 rep max. And so then they're saying 60 to 90% of that. So 90% of that is you're getting maybe 4 done, right? 6, something really low. And then if you're at 60%, you're gonna get a little bit higher in the reps. I wrote the second line right there. You don't need to start there, right? If you have not done strength training, you're not super active. Even if you are active, like I'm active, if I started right there, I probably couldn't walk for a week. So you do have to kind of build up your tolerance for that by starting a little bit lighter, easier, and then work your way up. The higher intensity, you're going to have the greater benefit. How often should you strength train? 2 to 3 times a week with that progressive loading. So I think a lot of times with my patients, whether they're in for something like strength training, helping with that, or if they have a problem with their shoulder or whatnot, and I give them an exercise and then I kind of check back in a couple weeks or a month later, how many reps are you on now? Oh, I've just been doing, still at the same 20. Right? Or still at the exact same weight. So you do want to progressively do more over time. And form is very important, of course. So inevitably everyone says, but I have knee problems and my shoulder problems and things hurt. So what do we do? So obviously joint pain can limit your tolerance for weight training. So this is where physical therapy is really helpful. So either treat the pain so then you can do the activity, or modify, find different ways. If you ever ask a physical therapist for an exercise for one muscle group, I've got 8,000 in my head. So if you can't do one, we can find another one. And then eventually get you to the point where you can handle the heavier loads, educate you on which things to avoid. So if you have a history of a rotator cuff repair, we have different shoulder things we're going to do than someone who's never had any issues with their shoulder. And then there's something called blood flow resistance. I just wanted to bring this up specifically because there's actually research that it's just as beneficial as really heavy lifting, but it's easier on the body. So this is a picture of me putting a blood flow resistance cuff on she's a pretend patient, actually. It's not a real patient. It's one of the club members. So what it does is it's restricting your venous flow, but it allows some arterial flow. It is a class 1 medical device. It is a tourniquet, but I don't use it up at the 100% tourniquet amount. So it creates low oxygen, high metabolite environments. And so you can strength train with very low load exercise. So I'll give you an example. If I did, one group does a 2-pound bicep curl. If you've ever done that, that doesn't feel real hard. Then we take another group and they do the same thing, but they've got the cuff on. And then a third group is doing 20-pound curls. Okay, so the 20-pound curls and the 2-pound with the cuff on will have the exact same changes in their strength gains and the hypertrophy of the muscle. Where the group that did the same exercise but they didn't have the cuff on will not have gains in their muscle strength or their hypertrophy or how big the muscle gets, because it's not enough load for that. Okay, so why do we do this? It's ideal for injuries, right? Post-surgical or for those in pain. I had a knee surgery and I was supposed to, start my strengthening phase. I'm not strong like Sarah, but I'm pretty strong. I was trying to do a single leg press with 70 pounds and it felt like an ice pick in my knee. I just couldn't tolerate it. So I'm at the point where I'm healthy enough in theory to strength train, but I can't get my strength back because it hurts too much. Well, lucky for me, I got access to a blood flow restriction. I used it for about a month. Of course, I had more access than other people, so I got to use it a decent amount. But within a month, I was up to 130 pounds with a 1-rep max. So one leg could push out 130 pounds, where a month before it was 70 with severe pain. So it works really well, and research shows that you can strengthen with just 20 to 30% of your 1-rep max, which is honestly, it's pretty wimpy. I put my mom on a leg press at, I can't remember, it was like 11 pounds or 18 pounds. I mean, it was pretty light, and she did tap out by the end of the exercise. So it gets very hard by the end, but the amount of stress on your joint is 11 to 18 pounds. So that's why you can tolerate doing it. So it improves your muscle protein synthesis, boosts the growth hormones, improves bone formation markers, bone mineral density, reduces your bone reabsorption. So it does all the same stuff that a lot of the exercise does. So this is what we do for people who say, I can't exercise because I have too much pain. Okay, so now we're going to talk about some other things that are very helpful, plyometrics or jumping. So jumping, skipping, running, anything like that. There's something called ground reaction force. So when I walk, it's a little bit more than my body weight that comes back up through the floor and goes into my bones. If I start running or jogging, that's going to go up exponentially. So I have a lot more force going through my bones with running and jumping than I do with walking. And so we really like people to do some type of jumping for their bone health. Even a study showed that 10 to 20 jumps per day with good form and progression has been shown to improve the bone density in postmenopausal women. And as Sarah alluded to, we will try jumping in a minute. So how about cardio? So back in the day, not that long ago, that's what we did to lose weight and stay fit, was cardio. So there's still benefits to doing cardio. Preferably you do cardio with a weight-bearing activity. So walking, running, dancing, things like that, as opposed to like swimming, because the impact is really helpful for your bones. But the aerobic exercise supports your cardiovascular health, your insulin sensitivity, mood, and that kind of thing. And then it can support your bone health and reduce your risk if you kind of do the weight bearing with it. So what is better, aerobic exercise or strength training? So the strength training will build lean muscle, which makes our resting metabolic rate higher. So we burn more calories at rest. So I would say 1 up for strength training there. There's something called HIIT training, the high intensity interval training. This is kind of probably my favorite, because you're burning a lot of calories in less time, but it also elevates your metabolism for hours after. So this would be, I'm going to do a higher intensity activity. I just think like, I don't know, jumping jacks or something like that. And then I'm going to do a lower intensity like strength training. And then I'm going to go back and do a higher intensity. So you're kind of just cycling through that. So both methods improve your insulin sensitivity for aerobic exercise and strength training, hormone balance, and body composition. So they're all good. But the strength training also preserves your lean muscle mass, especially during weight loss. I know a lot of the weight loss medications that people are taking, a huge issue with that is losing muscle mass. So it's important to strength train when we're losing weight, and it prevents that metabolic slowdown we see when we do cardio only. So again, aerobic training is still good for cardiovascular health, but if we do some muscle strengthening paired with it, that's going to be beneficial. And a meta-analysis where they're looking at a bunch of studies and looking at the results and analyzing them, the resistance training should be prioritized in fat loss prescriptions because it also preserves muscles. Okay, next, balance. So I put this in here because almost every single patient of mine gets a recommendation for balance when they see me because it actually starts to decline in even as early as our 30s, for sure in your 40s. So when people start falling when they're 80, it's not because they got bad balance at 79 and a half. It started years earlier, so I think we should all work on it. So it's subtle at first, a little slower reaction time, a little reduced coordination, a little less stability during dynamic movements. But by age 50, the balance starts worsening significantly every 5 years. So falls are the leading cause of injury-related deaths in older adults. If you're active like a pickleballer, sorry, we have pickleball here, so it's also the leading cause of fractures. So strength training, flexibility, balance training, all work on that. And so I think it's really important that we all have balance part of our day. So here's our exercise break. So everyone stand up for just a second. So we're going to do 2 tests. One of them you are going to stand on, pick the leg that maybe you would kick a ball with. You're going to stand on that leg, and we're going to try not to do with the arms. You're just standing on one leg with the eyes open. And I just want to see how easy that is for everyone. Some of you are like me, working hard at it. Some of you are like, this is no big deal at all. Okay, so now that we got that figured out, let's try closing your eyes and see how y'all do with your eyes closed. And we're going down. Okay, so why is that? So we have 3 balance systems. You have your eyes, that's everyone's favorite. We have your inner ear, not the favorite. And then you also have sensation from your feet and your ankles and things like that. So when we close our eyes, we're going to work on the weaker 2. So when people say, I work on my balance every day, I do yoga and I stare at my spot and I get myself in whatever pose, I think that's better. That's absolutely better than nothing. And I'm glad people do it, but I would much rather people close their eyes and balance. Now, if you're closing your eyes like me, if I close my eyes, this is my true balance here. If I close my eyes, it won't take me too long till I tip over. So I don't want to start there with my balance. I'm going to put one foot maybe in front of the other, and I'm going to try that. And if I can do that fairly successfully, but I'm working really hard at it, that's the perfect balance. If you are steady Eddie, you need to make it harder. If you're falling all over the place, you need to make it easier, because your brain will only figure it out if you're successful while you do it. So if I put my feet like this and close my eyes, it's just not going to be hard enough. I'm not going to get any better. But if I'm trying to stand on one foot, I'm tipping all over, that's not helpful either. Okay, now we're going to try a little jump test as best you can. So you have 2 options, or you can do both. Jumping on 2 legs, you would jump 20 times, and or you can jump on one leg 10 times each. Now, what's a jump? Okay, so anytime our feet leave the floor, so that is technically a jump. You can imagine the forces going through my bones here are not as much as if I did like that, right? If you can hear me, then there's a lot of force going through my joints. I have a bad knee. I would say that didn't feel great, but it didn't feel too bad. So let's try it out. So you get to pick 2 legs or 1 leg, whichever one you want. And you're going to do 10 or 20. Ready? Okay, ready, go. Okay, so if you did that every single day, that's the research study that found that that's very helpful for your bone mineral density. I would suggest maybe doing a couple times a week, doing maybe more than that would be more beneficial, especially if you're trying to prevent injuries and be good at your sports and whatnot. But if you're just looking at bone mineral density, some impact like that is very helpful. Okay, you can have a seat. Okay, so here's my recommendations for each of the type of exercises. For strengthening, it's 2 to 3 times a week. Great if you can do compound movements, squats, deadlifts. I always say if your head is moving with the exercise, you're going to get more out of the exercise in general. If you're standing in one place and your head's not moving at all, it's just a little easier on your body. So compound movements are good. Again, lift heavy enough that you reach failure, ideally, eventually, 6 to 10 repetitions. And we already talked about the benefits. Aerobic training, so they recommend 150 minutes of moderate intensity. So if you want to know what that is you can talk, but you can't sing. So right now, because of my jumping, that was moderate intensity because I can still talk to you guys. You can hear I'm slightly out of breath, sadly. But maybe I couldn't sing a song, especially while I was doing it. Now, while I'm jumping, that's going to be vigorous activity, right? I can hardly talk. I can get a couple words out, if you've ever talked to someone while they're exercising, that's going to be something called vigorous activity, and that would be 75 minutes a week. So you can do 150 moderate intensity or 75 of vigorous intensity. So brisk walking, cycling, swimming, dancing, and we talked all about all the benefits, but if you can combine it with strength training, you'll prevent that muscle loss. Again, the plyometrics and jumping, 1 to 2 sessions a week. So you don't have to make this a big production, but high quality, and you're actually doing some pretty good jumps. Or you can do that smaller daily quantity of the 10 to 20, or in a perfect world, you're doing both. Hopping, squat jumps, right, where I'm kind of jumping up and down, skater lunges, box jumps. So there's lots of different options for this. And it also prevents injuries as well. Balance training, it'd be great if you could do some version of yoga or a Tai Chi where you're prolonged period of time you're working on your balance. If you go, I have a lot of patients who ask, how do I find these? But if you go in like a community center or whatever gym, they have all of these classes usually. And then everyone should have, at some point during their day, do eyes closed. So this could be like, I better brush my teeth with my eyes closed. I put something in the microwave, I'm going to close my eyes and wait for it to be done. Or I'm going to do some squats with my eyes closed if my balance is a little better. Toe to heel walking, standing on one leg. So a lot of options. Start early though. Okay, so I mentioned today I have the HIIT training class tonight. So that's that high intensity, lower intensity, high intensity, lower intensity. That's a type of exercise that would be really good in this group. And then in August, I'm doing a women's strength circuit specifically. And so those are really good options if you're wanting to kind of jumpstart things or you want someone to help you out a little bit with that. It is group training sessions though, so it's not like one-on-one. But those are some options that I hold here. Okay, so summary of what you learned. So we know that perimenopause, menopause are due to hormonal changes in the estrogen and progesterone. There's many unpleasant symptoms and concerns. We can manage those through nutrition, lifestyle, exercise, supplements, hormones, prescriptions. And comprehensive care also includes individualized treatments. Either physical therapy myself or functional medicine and pharmacy with Sarah are 2 great options, not the only options. Okay, so if you want an individualized treatment program with me, for anyone who attends today, I'm giving a 50% off of a 60-minute evaluation and treatment where I go over your musculoskeletal history, so all your surgeries and injuries and things like that, your health history, your individualized goal. We kind of do a head-to-toe body screen to assess for areas where we need a little focus. Give you kind of a report of my findings, and then I provide customized exercises and videos for home and start you on that workout. But because it's heavily discounted, I can only do 3 of them, and you have to sign up today to get that special. Okay, and then after today, I'm going to send an email out with a copy of the slides from my presentation if you want that. And then if you're ready for an individualized program, you can contact myself or Sarah. On the back of that thing, there's also a QR code you can scan to book yourself. Okay, any questions, comments? Everyone gonna go home and jump and work on their balance? Yeah.
It was just random. I was just like, I'm just gonna start jumping.
Yeah. Yeah. Well, because I think, once we start getting 40s, 50s, our tendons actually become less elastic as well. And so that's when we start getting all the tendon issues like tendonitis, rupturing things. And so plantar fasciitis, different things. So all of that stuff, if we can make the muscles and tendons more resilient, one way we do it is strength training. Another way is through plyometrics. But you might not be able to start there if you're already in pain and whatnot. So, yeah.
I just want to say that I think this is great. And
Great.
I wish I would have heard about all this even earlier on.
Yeah.
Because I'm 57.
Yeah.
But I'm going to take a lot of this. And,
listen, y'all are way younger than me. And this was informational, but if you don't want to be falling apart like me, you better be doing some of this stuff.
That's right. Yeah, exactly.
I'm
Learn.
going to ask a question.
Yeah.
What is the difference between osteoporosis and arthritis?
do you want to take it?
Yeah, sure. Yeah, either way.
So osteoporosis is that your bones are like, for lack of a better word, like breaking down, shrinking, and are not building back up. Arthritis is inflammation in the joints. So you can have both, which is like neat, but osteoporosis, usually they look at your spine and they do like a hip reading and a spine reading, and sometimes they do a wrist reading depending on your
The
history.
DEXA scan.
Yeah, and so they look at normal. So like Keely and I are the same age, so we should have similar, like T-score they call it. So they're gonna scan my spine and say, oh, Sarah's spine is not as nice as Keely's because she's a physical therapist and she's jumping every day, but they're close, so you get like these ranges. But arthritis is that the joints kind of break down because they start to get inflamed and then you lose mobility. So
Start jumping, everybody.
Yeah, right. And then there's different types of arthritis. So osteoarthritis is different than, so we have psoriatic arthritis, rheumatoid arthritis, and things like that.
and
So,
it's kind of like what causes it versus like
right.
what.
So they're all inflammation of the joint caused from different things. Osteoarthritis is wear and tear, that kind of thing. Yeah.
So can you be tested to see if you might be in the early stages of osteoporosis, or how do you?
Yeah, I believe. I thought maybe it started at 50. Usually at physicals,
I don't know. I'm not there yet.
Like 50-ish or 55, 60. They usually start if they're worried if it runs in the family or if you're a smaller stature. But it's just you can pay out of pocket for the scan, but most insurances I would say cover it. But it's something where it literally the whole thing probably takes 20 minutes. It's longer to do the paperwork. You lay on your back and a little scanner goes. And if you're claustrophobic, they can do the wrist. The spine is a little bit more. They have more data with the spine, I guess, is the correct term.
Then osteopenia, if you've heard of that, is kind of like the precursor to osteoporosis. So some people will get that as a diagnosis as
And
well.
I don't even know what osteoperfect is.
I don't know. I don't know where they define it.
Osteopenia and then normal.
Yeah. All right. Anyone else?
Are there anything good about menopause?
No
periods.
Yes, I was gonna say. I'm like, I know one.